Some people have asked me, what does it mean to be patient-centered? Well, it's a complex issue, but part of it is inquiring of the patient's circumstances. It's one thing to have someone come in with their name and address and lots of social information that's billing related. It's another to know really about them. Where do they live? Who's around them? What is their attitude toward their condition or illness or staying well? And can I categorize that in a useful way? That's where our patient-centered assessment method comes in. By being patient-centered, we can help us understand them, not just they understand us. And I think that's helpful. Regarding mental health, one of the things that's troublesome to many of us is that when someone is sad and blue and discouraged, we quickly label that as a medical diagnosis, let's say, of depression. But it could be that that's a normal reaction to poverty or unsafe housing or economic disparity or lack of a meaningful job or overwhelming family responsibility for others who are ill or doing all that while raising children and taking care of aging parents. When we call that a simple thing and want to treat it with medication, it's actually completely underestimating the impact of what is happening around them and to them and how they might constructively deal with it. And we can't fix the world, but we can A, understand what people are up against, and B, understand which areas we actually might be able to find resources, if not within our own clinics, in the community to help them. And by doing that, we can be more useful than just prescribing a medication. So when people have things happen to them, what do we do to help them other than just name it with a medical diagnosis? Other parts of the world actually adapt. They create social support systems informally and formally to help do that. And actually the whole field of mental health is now learning that housing, for example, and education, for example, have a huge impact on everything from depression to psychosis. So people that are accountable for the triple aim now, where they're accountable for cost improvements, quality improvements, and patient improved satisfaction and experience, find that when patients are managed in a way or helped in a way that addresses their real needs, not just our medical issues, they get better. And they need less medical resources in the long run, which helps everyone. So this method of assessing their social context and understanding the social dimensions of their lives is helpful in a concrete way for me as a physician. And it doesn't mean I have to do everything myself, but it means I might meet a different team that would include more community engaged people like social workers or community EMTs or community health outreach workers that can help us help the patient in a way well beyond what we can do in the office. One of the questions that comes up is, how do I actually use this tool? How do I use PCAM in the real world in a busy ambulatory practice? Well, there are several ways we've learned. One of them is sometimes the physician or the provider might directly inquire of the patient of these questions I'll go through. The other thing that could happen is a nurse could do it in the regular office interview as part of entry into the clinic encounter. Third would be a care manager might use it who's already engaged with the patient and wants to understand what is the trouble? Why is the person not getting to the point of health, not improving as expected given routine care? So there are many ways it could be used and by different people. So let's say you're the one using it and you want to know how to introduce it. So I'll go through a scenario as if I were interviewing as the doctor and you're the patient, and I'll do my side of the conversation. I'd say, hello, ma'am, how are you doing? I'm glad you're here today. In order for me to better understand your world and your circumstances, I have a little tool I use to help me understand exactly what your life is like better than I do now, and help me assess where I might be able to offer more support than I have in the past. For example, in thinking about your well-being, are there any symptoms or problems that you think you're unsure about that might need further investigation? Are we on the right track from your perspective? And again, the patient might say, you're right on track, I believe everything you say, or you haven't a clue, I don't think you're on the right path at all, but at least now I know. I thought I was making sense of treating this condition. The patient might tell me, no, you're not even close. So we can negotiate what it would take to agree that we're going in a direction that's helpful. And what's impacting your mental well-being? Notice I use the term mental well-being rather than mental health. Mental well-being is a state, it's a circumstance that says I'm either doing pretty well or I'm not, or I'm disturbed about something. It doesn't automatically imply an illness. I could be discouraged because I lost my job. That's not an illness. I could be discouraged about a lot of things or happy about a lot of things. That doesn't make me either depressed or manic. It just makes me normally reacting with an intact brain to what's going on around me. That's a good sign. So that's an asset that somebody has that I could say, well, congratulations. It might be appropriate to worry about your next job. Are you applying? And we could address that. So that's one way of doing it. We can ask about lifestyle behaviors, and those kinds of things also affect mental well-being. Sir, are you active? Or ma'am, are you active right now? Do you walk, or do you enjoy doing something that gets you up and out of a seated position? And we could talk about that as a reference to being well, not necessarily just being ill. And we can help understand if it has an impact on their sense of well-being. One of the advantages of adding the patient's social complexity or social determinants of health to the equation of helping people in healthcare systems is that it gives us a new whole dimension of need that we've been ignoring in a systematic way, not addressing. So for example, if we had an axis with a vertical axis for healthcare complexity, that vertical axis would include diagnoses and severity scales that would go vertically. So we add hypertension, diabetes, osteoarthritis, depression, obesity together, and we have a complex patient that we can all look at and say, yep, that's complicated. We better do something more than simple work in order to help that person. What we've not done is a horizontal axis that would be their social dimensions of health. Do they have safe housing? Do they understand the terms we use? Do they believe our diagnosis is in an area that they care about, that's relevant to their own well-being? Do they have support economically to follow through on the recommendations we have? Is their care coordinated? Because if it's uncoordinated or not connected to each other, we get into competing care plans that undermine each other. So that lateral or horizontal axis is a dimension we haven't addressed. And if we have high levels of medical complexity vertically and horizontally high levels of social complexity, if you make a curve in those both dimensions and put a dot on the chart, you have a wall, a vertical wall, a barrier to their health that we haven't addressed. We've been to dimensions of one type, but we haven't created the other horizontal dimension. That's where the patient lives and works and has to deal with their illness and health. So when we do both dimensions, understanding both dimensions doesn't mean we can fix it, but we can understand it. And when patients are not doing well, it'd be a good time to inquire, are there other things going on? Those other things have names, if we can agree on them, and terms, such as PCAM would address, that we can then agree where we need to intervene on that social horizontal axis, not just on the vertical axis. Then we can actually be more constructively helpful.